Alright. Hey, brilliant minds, welcome back to NeuroClarity, where complex neurology becomes crystal clear. I am your host, Honorary Victor, and in today's episode, we are going to be exploring four real world clinical puzzles. We're going to be moving from mysterious brain bleeds to deceptive strokes and misunderstood pain syndromes. You are in for a deep dive into how hidden dangers within the brain reveals themselves. So, grab your coffee, stethoscope, or curiosity, whatever fuels your neurons, and let's get started. As usual, our cases are derived from Ching and Cheng's comprehensive review of clinical neurology. We've done questions 1 to 50, and we are going to be doing question 51, 52, 53, and 54. And that being said, let the clarity begin. Question 51. An 82-year-old man presents with intracranial hemorrhage affecting the entire left temporal lobe. He has a history of 3 intracranial hemorrhages in the past. An MRI obtained a few years ago for evaluation of dementia and prior to his current hemorrhage is shown in figure 2.14. Let us take a look at that. Back to our question. Which of the following is the most likely diagnosis and cause of his current hemorrhage? A. Amyloid angiopathy. B. Intracranial aneurysm. C. Anticoagulation. D. Hypertension. And E. Venous sinus thrombosis. Let us take a look at our MRI again. What do you think? So, as usual, I like to start with the MRI findings. Let us take a closer look at the MRI in front of us. You can't see it, but I want you to imagine a soft grayscale image of the brain, an axial slice, as if you are looking up from the neck into the head. The eyes are bright and round at the top of the image, and the rest of the brain fawns out like the wings of a butterfly. But here's what should really catch your attention. Scattered across the brain, mostly in the outer cortex, particularly the temporal and the occipital lobes, are small, dark, circular spots. These are jet black, like tiny ink blots on a page. These are not tumors. These are not calcifications. So, what are these? Well, they are microbleeds, and GRE MRI, also known as the gradient recalled echo, is the perfect sequence to catch them. What you're seeing is classic for what we call cerebral amyloid angiopathy. And this is where fragile blood vessels leak and leave behind tiny hemorrhagic footprints. Think of them like old scars, each one a silent sign that the brain's small vessels are weakening and bleeding. Now, how do we know it's not something else? Well, the distribution matters. These spots are in the lobar region. They are not deep in the basal ganglia or in the brainstem, and that rules out hypertensive microbleeds. They are numerous, they are cortical, and this suggests a vessel pathology that lies in the cerebral cortex small arteries, which is a hallmark of amyloid angiopathy. Also, I want you to remember that GRE, that is graded record echo, show blood as black, and that's because it is sensitive to magnetic susceptibility, specifically to something we call hemosiderin, the iron-stained residue of broken down blood. So, when we say the brain is peppered with microbleeds, this is exactly what we mean. So when you are reviewing a GRE MRI and you spot multiple dark spots in the cortex, pause. Consider amyloid angiopathy, especially in older adults or those with lobar hemorrhage. This isn't just an imaging quirk. It's a clinical clue to a potentially devastating condition that can result in recurrent brain bleeds. What is black on GRE may actually shine the brightest light on your diagnosis. So back to our question, we can see that option A, Amyloid angiopathy is the right answer. Next question. Question 52. A 49-year-old woman suffers an acute ischemic stroke, producing significant sensory loss on the left hemibody. About 3 weeks later, the patient comes back to the clinic and complains of severe painful sensation when touched superficially, as well as deep burning pain in the same region. Which of the following is the most likely diagnosis? A. Medullary infarct. B. Midbrain infarct. C. Caudate infarct. D. Pontine infarct. And E. Thalamic infarct. What do you think? As usual, we are going to dive into this question by breaking it down step by step before we give an answer. We are told that we have a 49-year-old woman who had a stroke and now she is dealing with something unexpected. 3 weeks ago, she had the stroke on the right side of her brain. At that time, she lost feeling on the left half of her body. The arm, the leg, and even her face felt numb. And that makes sense, right? Strokes affect the opposite side of the body. But here's the thing that gets interesting. She is now back in the clinic, and instead of feeling numb, she says even the slightest touch feels like burning fire. A simple hand on her skin feels like electricity. The breeze from a fan feels painful. And this is something we call Dejerine-Roussy syndrome. Dejerine-Roussy syndrome is also called thalamic pain syndrome. Let us break that down. What part of her brain was affected? The stroke hit a part of her brain called the thalamus. The thalamus is a deep, egg-shaped part of the brain that works like a busy post office. It sorts and sends out all your sensory information, including touch, pain, pressure, temperature, all of it. When the thalamus is damaged by a stroke, those sensory messages get scrambled. At first, there is numbness because the signals are cut off, but later the brain tries to recover and then the wiring gets confused. Suddenly, non-painful things feel painful. That weird burning electrical pain-like sensation is something we call allodynia. Why does this happen? After the injury, the brain sometimes misinterprets sensory inputs. It's like a radio with broken dials. Everything just sounds wrong. Because the thalamus is the main hub for sensory signals, its damage causes strange sensations over one side of the body, from head to toe. The key points to remember include 1. Dejerine-Roussy syndrome happens after a thalamic stroke. 2. It starts with numbness and later becomes painful. Even gentle touch feel awful. And lastly, it can be very hard to treat and it deeply affects the quality of life. So, next time someone tells you they had a stroke and now every touch burns, think thalamus. Think Dejerine-Roussy syndrome. I want you to also remember that the brain's healing process isn't always smooth. It sometimes rewires in very painful ways. That being said, let's go back to our option. So, from everything we've said, option E is the right answer, thalamic infarct. Next question. Question 53. Which of the following is incorrect regarding the posterior circulation? A. The posterior choroidal arteries arise from the posterior circulation. B. The anterior choroidal arteries arise from the posterior circulation. C. The anterior spinal artery arises from the vertebral arteries. D. The posterior inferior cerebellar artery arises from the vertebral arteries. And E. A segment of the vertebral artery runs through the transverse foramina between C5 to C6 and C2. What do you think? Now, I particularly like this question because it's less about symptoms and more about brain plumbing. Yeah, that's right. The blood vessels that keep our brain alive. We are asked which of the following is not part of the posterior circulation. And I'm going to give it to you straight. The answer here is the anterior choroidal artery. It does not arise from the posterior circulation. It arises from the anterior circulation. Now let us unpack this step by step. What do we mean by the posterior circulation? I want you to think of the brain as a city with two main highway systems bringing in oxygen-rich blood. We have the anterior circulation, which supplies the front and top of the brain. And we have the posterior circulation that handles the back, including the brainstem, the cerebellum, the occipital lobes, and parts of the thalamus. The posterior circulation is built from the vertebral arteries, and these arteries come along your neck bones and join to form something we call the basilar artery. From this vessel, smaller branches come off like exits from a highway, and they supply deep and critical parts of the brain. Key arteries in the posterior circulation includes 1. The pica, also known as the posterior inferior cerebellar artery. This arises from the vertebral artery. Next is the anterior spinal artery, which is also from the vertebral artery. Next is the posterior cerebral artery, which comes off the top of the basilar artery. And from the posterior cerebral artery comes the posterior choroidal artery. Note the posterior choroidal artery, which supplies parts of the thalamus and the choroid plexus. Now, here's where the confusion happens. Since the posterior choroidal arteries come from the PCA, some may say, oh, the anterior choroidal artery should also be part of the posterior circulation coming from the PCA. But that's wrong. The anterior choroidal artery actually comes off from the internal carotid artery, which is a part of the anterior circulation. It is like a side street coming off from the anterior highway and not the posterior one. So, even though both the anterior and posterior choroidal arteries sound related, they start from different highways. Think of them like two streets with similar names in different neighborhoods. They do not connect at all. And why does this matter? This matters because understanding where artery comes from will help you a lot to interpret strokes, predict symptoms, plan treatment, and to ace exams. Yeah, ace exams. For example, a problem with the posterior circulation may affect balance, vision, or even consciousness, and that's because it feeds the brainstem and the occipital lobe. Whereas, a problem in the anterior choroidal artery could lead to weakness, vision loss, and sensory changes, since it supplies parts of the internal capsule and the optic tract. So, what's the takeaway? The anterior choroidal artery may sound like it's from the back or like it's related to the posterior choroidal artery, but it's not. It belongs to the anterior circulation, and that makes option B the correct answer in this case. So, our final question 54. A 29-year-old woman, a smoker on oral contraceptives with a history of antiphospholipid antibodies and a recent untreated left middle ear infection, developed headache and right hemiparesis, later becoming comatose. An MRI is obtained and is shown in figure 2.15. Let us take a look at our MRI. Which of the following is the most likely diagnosis? A. Hypertensive hemorrhage. B. PCA stroke with hemorrhagic transformation. C. Hemorrhage associated with amyloid angiopathy. D. Venous infarct with hemorrhage. And E. Subarachnoid hemorrhage. What do you think? Let us go back to our image again. So as usual, let us interpret our MRI. What you are seeing here is an axial flare MRI, a special type of scan that makes fluid look dark but shows abnormal tissue like swelling or scarring in brighter contrast. Focus your eyes on the right side of the image, which actually represents the left side of the brain in real life. Remember, MRI flips it. You will notice a bright irregular area in the left posterior frontal and parietal region. It is surrounded by dark patches and there is a subtle distortion of the anatomy. The ventricle, which is the fluid-filled spaces, are pushed to the right and there is actually signs of mass effect. That means something is pushing the brain tissue out of the way. This bright area is not just swelling, it's something we call a hemorrhagic infarct. But here's the twist. This bleeding doesn't fit neatly into any one arterial territory. It's messy. It spreads across borders, affecting both the middle cerebral artery territory and the posterior cerebral artery territory. Now that's your first clue that this isn't your classic artery blockage. This patient has a venous stroke, also called a venous infarction, which is caused by a clot in the venous system. In this case, the left transverse sinus. Let me explain. Arteries bring blood into the brain. Veins and venous sinuses drain the blood out. If those veins or sinuses get clogged, blood begins to back up and it has nowhere to go. That backed up pressure will cause swelling, reduce oxygen delivery, tissue death, and often hemorrhage that is bleeding into the brain. And just like that, we have a venous stroke. This woman had multiple reasons her veins could clot, and they include the fact that she smokes. Remember, smoking raises clotting risks. She's also on oral contraceptives, and remember that oral contraceptives are known to increase thrombotic risks. She has a condition called antiphospholipid antibodies, and this is a clot prompting autoimmune condition, and she has an untreated ear infection. Infections near the brain can spread and inflame venous sinuses. This wasn't just bad luck, her risk factors stacked up like dominoes. The tricky part of this condition is that it can look like anything. Headache is the most common symptom. You might see seizures, weakness, vision changes, and confusion. And in severe cases, especially when there's a mass shift, you get the coma, like in this patient. So, if a young person, especially a woman, comes in with a sudden bad headache and risk factors like birth control or autoimmune issues, keep CVST, cerebral venous sinus thrombosis, on your radar. How do we confirm this? You will need the right imaging. MRI of the brain might show hemorrhagic infarct, but to see the actual clot, you will need an MRV, a magnetic resonance venography. It shows the absence of blood flow in the venous sinus, and this is an example of one. How do we treat this condition? Even with bleeding, we usually treat with anticoagulation like heparin, and this is used to stop the clot from propagating. If the brain pressure builds too high, we might need steroids, osmotic agents, and even surgical decompression in critical cases. In some centers, endovascular clot removal is an option too. To wrap this up, what makes this case special? It reminds us that not all strokes are arterial. It teaches us to look for patterns that don't follow typical vascular territories, and it underscores the importance of recognizing venous infarct, especially in young women with risk factors. Stay sharp because when veins go rogue, the brain pays the price. Before we end this podcast, let me leave you with 3 takeaways. 1. Amyloid angiopathy causes lobar bleeds in elderly patients and shows up as microbleeds on GRE MRI. 2. Thalamic strokes can evolve into chronic central pain, which we call Dejerine Roussy syndrome, and this is due to disrupted sensory pathways. And lastly, not all strokes are arterial. Venous sinus thrombosis is a dangerous masquerader with unique imaging and treatment needs. And that's a wrap. Thanks for joining us on NeuroClarity. If you found this episode valuable, you can share it with a colleague, you can like and subscribe for more bit-sized brilliance in clinical neurology. You can follow us on X, formerly called Twitter, at NeuroClarityP. Until next time, keep those neurons firing and stay clear in the cortex. Bye for now.